My talk will be on the coronary imaging, as Dr. Hakim said, and also the intracoronary physiology. So in intracoronary imaging, the most important thing is the devices or the imaging modality that we use is IVUS and OCT. Well, as far as the physiology is concerned, we go with the FFR, IFR, and nowadays QFR. So I've tried to restrict my presentation. I'll try to finish it as quick as possible and try to make it as simple as possible to make people understand. So regarding the IVUS, we know that we have got two kinds of IVUS probes. One is the digital IVUS, the Volcano, and the other one is rotational IVUS, Boston Scientific, that we use nowadays in our lab. So the what important thing, why we go for IVUS? What's the importance of the IVUS? You know, the importance of imaging in nowadays coronary interventions. Without imaging, you cannot go for an optimal intervention without imaging. If you take the help of imaging, especially in case of left main interventions, complex interventions, calcified interventions, and bifurcations, without the help of imaging, you cannot go with very beautiful results in long term and short term. So the important thing that we look for the IVUS when we put the IVUS probe inside a vessel. So what we see. So you can see that the outer layer adventitia. The most important landmark is the media. You have to look for the media, and inside on the in the periphery there is adventitia, and in the lumen, between the lumen and the media there is plaque burden. There is lumen. So depends whether you see a healthy vessel or an unhealthy vessel. So what we see when we go for the imaging, what we see in the IVUS. So the important things are, when we are going for the diagnostic purpose, we look for the severity of the stenosis, the nature of the lesion, whether it is calcified lesion, it is lipidic, it is fibrocalcific, or it is a fibrotic lesion. And on the basis of the results, we plan whether we should go for the plaque modification, like with the help of, in case of calcified lesions, we take the help of rotablation, and lithotripsy catheters are for the, in the same way, if there is like just fibrotic lesion, we can go for the cutting balloons, or there are simple thrombotic or lipidic like lesions, then we don't need much gadgets, we can go with simple balloons. So the other important thing that definitely that affects your long-term results are the size of the stent and balloon you use in these vessels. So there are different studies which have shown a correlation between the FFR and IVUS. That what is the area, the minimum luminal area that is significant, and when you see such results pre and post, so you can plan your procedure. But the consistent thing among these the studies that compare the IVUS and FFR, the most important thing is that there is a good correlation between the IVUS and FFR when you go for the studies of left main, but there is no good correlation in case of other vessels. So there are different criteria which we use on the basis of the IVUS. For example, in case of left main, there is a cutoff that below which and above which you can decide whether we should go for standing up this vessel or not. But in case of other vessels, IVUS cannot definitely decide. The IVUS minimum luminal area cannot tell you whether this lesion is significant or not in case of other vessel. But yes, in case of left main, we'll discuss on it. We'll discuss this later. So in case of severity of the stenosis, if you go for the left main, a left main area of less than 4.5 is likely to have positive ischemia. And an area with 6 millimeters square and more is most probably, but you can say with surety that this is FFR negative and this will be ischemia negative. But in case of other vessels, IVUS cannot tell you whether this is significant. IVUS cannot tell you whether the lesion is significant or not in case of other coronaries. So if you want to assess the area, you can just assess the area of the left main with IVUS. But you should go for IVUS if you have the facility to assess the lesion, as we discussed the nature of the lesion and the plan. So, but important thing that FFR FFR results may have limitations in case of left main, because the left main, if there is ostial shaft lesion, fine, you can use FFR, but most of the time left main lesions involve the bifurcation, and there's also a striatal lesion and the other branches like circumflex and LAD. So in this case, IFR will be superior. So in case of acute MI, in case of the lesion morphology, the structure of the vessel, you can understand from the mnemonic AMI, in which we see for the adventitia, media, and intima that I discussed in the previous slide, and also discuss in this slide. So you can see, most important, when you see the IOS structure, you should look for the black line that shows actually the media, extranelastic lamina and media, that you can see that this jet black line. So you should first of all have a look on this. Anything beyond this is adventitia, anything inside will be towards the lumen and intima. So this is the IOS catheter, and this is the smooth muscle in the media, and this is the blood pool inside the lumen. So this is actually the intima that lines the media, and anything you can see, if this is so much thick, because we know the intima is just endothelial lining. So if this is so much thick, it is nothing other than a lesion. Now, depending upon its composition, you can decide whether it's calcified or lipidic or fibrotic. So you can see as concentric plaque, you can see that it is present in 360 degrees. This is the lumen. As we decided, this is the media, and anything beyond media is adventitia. So all this lining is thick plaque. So how we see the fibrotic lesions and how we see the calcified lesion, if we look at this picture, you can see that this is, as we discussed, this is the adventitial layer, and media is most probably here. And this white lining, the calcium and fibrotic lesions, these look white because of increased reflectiveness. But when you can see, you can appreciate the tissue or the structures beyond this white line, it means it's not calcium, it's fibrosis. When you're not able to see anything beyond, it means there is a calcium spur. So most probably this area is the calcium, that you cannot see anything beyond it because of reverberation effects. And this is fibrotic lesion that is surrounding all the lumen of the vessel. And as we discussed, you can see the calcium. This is the fibrotic tissue, you can see, and this is the thick chunk of the calcium, and that is, you cannot see anything beyond this. Now, depending upon its position, whether it's a superficial calcium or it's a deep calcium, if it is like within the 50%, in the internal layers of the vessel wall, it is, we decide that it is defined as superficial calcium. If it's present in the deep layers of the vessel wall, it is defined as deep calcium. So on the basis of its position, you can decide the modality, that what should you use. When it is like superficial calcium, because it's close to the lumen, you can use any of your gadgets that can break this calcium. Like you can use rotablation, and you can use your balloons, cutting balloons. But in case of deep calcium, rotablation, cutting balloons will not help you definitely, because this cannot reach the deep layers of the vessel. So in that case, you have to go for the lithotripsy balloons. So calcium, on the basis of the presence of the calcium, whether it's present in one angle 90 degrees or it's for more than 90 degrees. So we decide the one arc as 90 degrees. It can be a single arc 90 degrees or two arcs, or it can be circumferential, present in all circumference of the vessel. So for the stand sizing, remember this, there is an intrinsic problem with the IOS, that IOS will always oversize your vessel. So when you plan, that is almost 10%. When, for example, IOS shows that the vessel size is 5 millimeters, it means it is 4.5. So you should plan your stand and the post-dilatation balloon according to it. So you should remember this thing. And for the qualitative IOS assessment, what are the other important things or information that we can get from the IOS? These are the IOS, for example, edge dissection, we can see. You can see the edge dissection over here, and you can see the residual plaque burden. Why should we look for the residual plaque burden? I'll go to the next slide, and what are the important things that you should look when we are doing IOS. So I think that it will be more clear in the next slide. So for the stent expansion, you should try that to make your stent as eccentricity should be avoided. It should be as circular as possible. And for the malapposition, you should look that for the difference between the under expansion and malapposition, we should understand this, because when the old stent is like not touching the vessel wall, it is under expanded stent. But if few struts are not reaching to the vessel wall, it is malapposition. So we should avoid these things. Then tissue prolapse, we can also see it can be in the form of, especially when in patients who are having fibrotic lesions. Sometimes when you use any stent that's with low radial stent, tissue may prolapse inside the stent with having open cell. So there is possibility of the tissue prolapse that we can see in the IOS. So thrombus, we can see thrombus here with irregular margin inside the lumen. So remember, in this case, when you're looking for the thrombus in ACS, IOS OCT is a better modality as compared to IOS that can that can tell you better the differentiation between the red thrombus and white thrombus. And in the same way for the edge dissection. And so there are multiple trials, but two important trials was the IOS XPL and Ultimate trial. So on the basis of this, certain guidelines were made, especially by the European authorities, so, on the basis of Ultimate trial. So what are the important criteria we should look when we are doing IOS? What should we look for? So we should the three important things we should always remember, that when you are doing IOS and you stented any lesion, you should remember that your minimal lumen area should be more than 5 millimeter at least. More than 5 millimeter, it should be at least 90% of the distal reference area. So what's the difference? This distal reference area or proximal reference area? It's an area, the area that has less than 50% of the plaque burden. That should be like the area, your target area that where you are standing. So you want to put your stent from the proximal to the distal landing zone. The proximal and distal landing zone should be disease free. It should be ideally less than 30%. Plaque burden should be less than 30%. If not less than 30%, it should be at least less than 50% plaque burden. So in this case, you can avoid geographical maze. That's the definition of actually geographical maze. When your stent is landing in a zone in which there is less than 50% plaque burden, then it means your long-term results will be good, because there are chances of dissection in such area, the chance of restenosis when your stent is landing in such area where there is more than 50% plaque burden. Number one. Number two. Number three, you should avoid any edge dissections, any dissection that is involving the media, or it is more than 3 millimeters in length. That is important, especially in the distal edge. That should be fixed. So this is the summary for the stent optimization when we are doing IOS. So it is a bit blurry, but as we discussed previously, you should have a minimal stent area that should be more than 5 on IOS, or it should be more than 4.5 on OCT. And there should not be any important malpositions. But remember that the long-term effects of malposition are not well known, but definitely when there is under expansion or stent edge dissection, these have definitely that can increase your mace. And large dissections, as we discussed, these should be less than 60 degree arc, and these should be less than 3 millimeter in length. So in summary, remember this IOS provides us with diagnostic information on the basis of which we can decide the lesion type, our gadgets, how to prepare such lesions, and we should go for stenting or we should go with POBA only, and also the way how to prepare these lesions. For example, we should go with the rotablation, we should go with cutting balloons, or we should go with lithotripsy, and definitely the size of the balloon and stent. These are also important informations to avoid any undersizing, and also optimize the stent and avoid definitely long-term complications. So because the topic is extensive, I have tried to make it a bit small. So next thing is the OCT. If you compare the different modalities in angiography 1958, then IVOS 1988, then in 1996 OCT came in clinical use. So the resolution of the OCT is far better as compared to the other modalities. So you can compare the IVOS and OCT images. You can see, as we discussed, the intima, media, and adventitia. And also the plaque type, you can see in case of OCT, SCT gives you definitely better results. If you see this calcium, how we see the calcium important, any fibrotic lesion will have high back scattering. It's very shiny. In case of IVOS, we saw that calcium and fibrotic lesions were almost looking same. But in case of OCT, the fibrotic lesions are shiny, but the calcium is not shiny, but it's very well demarcated. You can see the edges, so you can differentiate the calcium better with OCT from the fibrotic lesion. So you can see this calcium, and also you can see this calcium in the edges, and also a lipidic core. If there is no, look the calcium, you can see the edges very sharply, but in case of lipidic core, you cannot see the edges sharply. So this is a pool of, just like pool of mud. If you see the lipid pool is just like a pool of mud, definitely. You cannot see anything beyond that. So what are important information that we can get from the OCT? So OCT is, as the resolution is far better. So you can see the thin cap fibroadenoma. Thin cap fibroadenomas, by definition, these should be less than 65 microns. So these are the lesions which mostly cover the lipidic core, and these are the lesions which are prone to the rupture. So these are the lesions which we can see in patients with ST elevation myocardial infarction. So in the same way as we discussed, you can see this ruptured plaque, lipid core here, and the other important things are thrombus. Definitely we will not be able at our level to differentiate the cholesterol crystalline macrophages, but we should definitely differentiate the thrombus, especially the red thrombus from the white thrombus. White thrombus will be white, the reflectiveness is good, you can see anything beyond it. But the red thrombus will not let the light to pass beyond this. So it is red and it will not let the light rays to pass. So this is the main differentiating factor between the white thrombus and red thrombus. So how can you see different complications in case of when you use the OCT? So you can see dissection, how you can see better if you compare it with the IVOS. IVOS will show you dissection, but it's very much clear with the OCT, that the flap, dissecting flap. And in the same way, you can see malposition very well here, but it is definitely, you can see it over here, but it's very well, you can see the studs which are away from the vessel wall. And also the tissue protrusion, you can see very beautifully over here. So when you are going to interpret the OCT images, so first of all, you should look whether you can see the external elastic lamina or not. If you cannot see it, if you can see it, then you should, this is actually a chart on the basis of which you can simplify how should you look at the image when it comes in front of you. So normal artery and fibrotic, fibrotic lesion. When you can see the external elastic lamina, it means whether it's a fibrous plaque or it's a normal artery. Okay, then you should, next thing is to go for the lumen. In case of lumen, for example, this one is eye attenuation, you cannot see anything crossing beyond this, so it is the red thrombus. But in case of white thrombus, it is white itself and you can see the vessel wall beyond it. And if there is eye attenuation, for example this one, as we discussed, you cannot see beyond this anything. So this is a lipid core. And when there is calcium, this is, you can see very well delineated margins of the calcium. So on the basis of your definitely OCT images, you can decide whether you should go for direct standing if there is like just a straightforward lesion and just a thick fibrous. If there is a thick fibrous plaque, you can go with the compliant balloon. If there is calcified lesion, as we discussed, you can go with the rotatripsy and the atherectomy, depending upon the calcium that's present. So the next thing is to go for the physiology. In physiology, the modalities that we use are the FFR, IFR, and QFR. So in FFR, QFR, and IFR, what basically we measure? Actually, if we go to the basics, we know that pressure is equal to flow into resistance. So, and resistance equal to pressure divided flow. That we remember the Ohm's law. V is equal to IR. So in the same way, we apply it over here. So the pressures we measure. So with these wires, we actually measure the proximal pressure that comes from the guiding catheter, and the distal pressure that comes from the that we measure with the tip of the wire, the FFR wire. So then we compare the ratio. So that ratio tells us about actually the flow, that how much flow we are getting, the vessel is getting beyond that lesion. So that's actually the FR or IFR. So if we go to this, if we are measuring these pressures in all cardiac cycle, so that will be the FFR. If we are measuring it only in one part of the cardiac cycle, in the diastolic phase, when there is no waves, then this becomes IFR. If you go in the same way, whether we are measuring these pressures at baseline, or we are creating some hyperemia, then we are measuring the pressures. So this is the protocol for the IFR. When we create hyperemia, this is the protocol for the FFR. So as we discussed, that we in case of FFR, we go for the whole cardiac cycle, we create hyperemia. But in case of IFR, we don't create any hyperemia, we just go for the diastolic phase pressures. So if you go for the resting pressures, again the thing is, as we discussed, baseline pressures are we create this is the IFR pressures. We just measure the pressures during a certain period of the cardiac cycle, in which, as the name implies, that's instantaneous free wave ratio. There are no waves in just this phase of diastole. You see, there is no waves. So this is the point where we use the IFR. In case of FFR, we have to measure from here to here, the whole cardiac cycle. We'll compare everything. So as we discussed, in case of hyperemia, we go for the FFR. And what is CFR? If you go for the at the baseline compared to hyperemia, if you compare the flow velocities, it becomes the coronary flow reserve. So what are the certain hemodynamic situations that can affect the results of the IFR and your FFR? If there is low blood pressure, like mean blood pressure is less than 60, or there is ventricular tachycardia, atrial fibrillation. So in that case, whether it is IFR or FFR, hyperemic is FFR, non-hyperemic is IFR. So both can give you the same results. When there is significant ectopy, you better go with FFR. Some patients who have used recent caffeine, remember that caffeine can affect the results of the FFR. At least patients should not take coffee for at least 24 hours. So if patients using caffeine, or the patient is not responding to the adenosine, he better be a candidate of IFR rather than FFR. And in the same way, if in case of ACS, you can use any of the modalities. But in ACS, for the non-capillary lesion, you better use IFR. So next, for the valvular heart lesions, you can use any of the modalities. And the hyperemic, sometimes patient will be with the problems with their lungs. So these are the patients we often think while using adenosine. So these are the patients in which, like low blood pressure, asthmatic patients, COPD patients, these are the patients in which you can use IFR. So then in the same way, cost saving, and when you have to use it again and again, so these are the patients in which you can use IFR in a better way. So this is the end of my presentation. Thank you.